2018 recipient of the award is a focused ultrasound pioneer who began to work on focused ultrasound 40 years ago, precisely with William and Francis Fry. So in one sense, the loop is closed today, because indeed the 2018 awardee developed with the Fry brothers the first clinical ultrasound-guided device for the treatment of brain cancer, and that was back into 1972. That was used for the treatment of glioblastoma. But he's also the inventor and the developer of the Sonablate HIFU device for the treatment of prostate disease and the co-founder of Focus Surgery. So please join me in congratulating Naren Sanghvi for the 2018 William and Francis Fry Award. Congratulations. Thank you very much. So, Naren will now address us on HIFU for the treatment of prostate cancer. Switch. Great.
This is to skip, right? Wonderful. So first, I want to say that I do work for Sonaca Medical, so this is the disclosure, and I have financial interest as well. Now, I wanted to thank all of you guys and the organizer of this meeting, because, you know, we always struggle to get great meetings going because there are so many meetings. But ISTU has been a great meeting for all of us. Also, I'd like to thank the board and those people who nominated me. Thank you very much. I'll talk today about the Fry brothers, a little bit of experience what I had with them. Then I was asked to talk a little bit about HIFU and its current status in terms of the prostate cancer treatment. And that's where the Sonablate and the ablatherm systems are used really for the treatment of cancer of the prostate. And then, of course, many of you touched the basis in terms of the promise of therapeutic ultrasound. And I'm a great believer that the sound energy has been with us, and it's really going to play a major, major role. You know, we have been kind of making small steps progress, but I think we have reached to a point where we are going to have a large jump in this area. So having said that, it's not just the Fry brother, it was the Fry family, in fact. You may not have heard, there were ladies who played a great role in the research what Fry brothers are doing. One was Ruth Fry. She was a mathematician, and she also published articles in Journal of Ultrasound, acoustic ultrasound, and primarily gave us the equations of the heat distribution. The other person was Elizabeth Kelly Fry, who also played a major role in developing the breast ultrasound for the early diagnosis of tumor. And she was pioneer, and because of her research, we have been using ultrasound as an adjunct to mammography now. And the third one was Marie Fry. Marie Fry was Frank Fry's wife, and they had adopted 12 children of all sorts of different backgrounds. And I was the 13th one. So, as you know, Fry brothers are well known, but also there were lots of people with the Fry, like Professor Fry Dunn as well. So they always promoted the people who came in touch with them. And by the way, Frank was very good, as you can see here, made all of us laugh and smile when he gave the talk at the ISTU 2002, where he received the Pioneer Award there. So this was a great event that Larry Crum and Gail Tahar organized and celebrated. We thank you there. And you have seen this before, the hypo lesions, what they created in the brain, that was tremendous in the 50s with whatever the instrumentation they had, and they gave us the inspiration that you can do wonderful things with ultrasound beams. This was the device that I was fortunate to work with Fry in developing the ultrasound-guided device for the treatment of brain tumors. And here what we see is a neurosurgeon, Dr. Heimberger. This was a classical situation where there were patients who were diagnosed with malignant tumors, and absolutely they had no recourse. And these were terminally ill patients. And they were treated with focused ultrasound beam was aligned with the therapeutic beam and the imaging beam, two transducers, to produce the ultrasound images such as that. Now, of course, we couldn't penetrate the sound beams through the skull, so the skull was removed, and that was a major problem for all of us, because this took a long time, and the skull was removed, and then they had to put it back. However, this patient did quite well in terms of their quality of life. So, given that the background and the history, I'll give you some background that we've been working on since 1990 on the prostate. And today I'll talk about whole gland ablation of the primary tumor, external beam radiation, failure tumors, and then we will talk about the focal treatment, and there are 2-3 posters on a focal treatment as well. So please go and see them. So what is our dilemma? Our dilemma is, Dr. Wu just told us that these are the primary tumors, and really, they have a 100% survival rate. About 80% of the tumors are detected early because of the PSA advancements, and so anything what we do has to be much better than not doing anything, because they can survive 5 years without doing anything. So we have to come up with a system that has, it's number one, it's efficacious. Number two, it has to be very, very safe. And the treatment has to be durable. So these were the challenges in developing these two systems that came into play in 1990s. One was the sonoblade, and the other one, Ablatherm. Basically the same background in terms of ultrasound as the imaging device, and then surrounded with the therapeutic transducer and a transvector approach. And this really worked out quite well. If you take a look at the brain, which was extremely complex, here is a very stable organ sitting in place and very easy to localize. So as you can see here, there are 3 planes in transverse plane. I'll touch base on the Dr. Uchira's work, who has been doing HIFU for whole gland prostate ablation since 1999, and he has published more recently in 2015 the data on different generation of the HIFU devices on 884 patients that he has been following. So what we learn from this is, number one, that 97.7% of the patients had an overall survival rate, means for 14 years onward. The second one is the cancer-specific survival rate is just about 100%. So what that gave us is a very high confidence that yes, you can treat the prostate cancer and you can improve the survival rate much better than 5 years. And as you saw that in a previous slide, there were higher PSA level as well in these cases. So HIFU did its job in carving out the entire cancer within those group of patients. We did multi-center clinical studies on external beam radiation failure patients, and the paper just came out this year on 100 patients that were treated. And these are the patients basically have a disease that is very difficult to treat. Even the surgeons do not want to touch them because their bowels are compromised because of the radiation treatment. The radiation comes from the pelvic region. So this was a challenge, and as you can see, within that 100 patients, 81% of the patients had a negative biopsy, and 70% of the patients, their PSA came down to 0.5 nanogram per milliliter, very, very close to like they have no prostate there. So, in conclusion, that this is an option for the patients, early stage prostate cancer, and those who do not want to go through the surgery. Now, this is in England. The prostate revolution is taking place. And it sounds like a kind of a story. But what's happening here is the class was offered prostate imaging and focal therapy in month of March. And that class was oversubscribed by end of March, and the class took place in the month of April. So here is the revolution taking place in terms of how do we treat the prostate cancer. And Dr. Hashim Ahmed has been doing the research in the prostate cancer for the last 10 years. And his contribution is coming to fruition in terms of saying, let's not target the entire organ, not take it out, but just treat the tumor. The reason he can say that is because now we have the focal ablation capabilities and the instrumentation available. So what we saw a revolution in the breast cancer treatment 30, 40 years back. There was lots of resistance. We were seeing not only one breast removed, but both the breasts were removed. Not only the mother's breast, but their daughter's breast were removed. Similarly, I experienced the same thing in 1970 when I went to see the urologist. They say you have to remove the whole prostate. It's completely opposite now. What we hear is, let's not do that, right? Let's only kill the cancer cells that are in the prostate. And that is what Dr. Ahmed is saying, and what they are saying in Europe, as well as in Japan and United States. Our devices are used for focal ablation. That was the name of the company, called Focal Surgery, by that. And that is exactly what Fries were preaching, called it focal ablation. And the reason for that is very simple. That if there is a young patient who is diagnosed with a prostate cancer, you do not do anything to that patient, and if the patient is healthy, he will do as good as the patient who had undergone the surgery. So surgery is nothing but a burden in terms of other side effects. So what we are finding out is, how do we know which prostate cancer is really a deadly disease? And what he calls it's called the index lesion. Or these are called the multifocal disease, but not all cancer cells are going to grow and spread everywhere. So the idea is to treat only one that is really going to be harmful. And we can do those things now because MRI has started to identify those group of patients, as well as they do what we call the targeted biopsy. And all this thing is available to these people or the doctors now because of image processing. Instrumentation has tremendously improved now, and it's accessible. So the next thing is to do is to take the MRI, which has found the tumor, and then do the fusion of MRI to the sonoblade or the ablative device. So the patient goes to MRI, has a targeted biopsy, the lesion is identified within the prostate, and those data then are inserted in the computer of the sonoblade machine, and given those three-dimensional aspect, and also what we call the correction factors to reconfigure the size and the shape of the prostate in relation to where it came from, with the deconfiguration with our probe, etc., is done online. So in 3D, then only the area that's going to be treated is the one that was identified with the biopsy as well as with the MRI. So now all of a sudden, you have a tool that is only going to treat the cells that are really what we call the index lesions and not the entire prostate. As you can see here, only half of the prostate, what we call the hemiablation, has been targeted now with the HIFU. And the cancer is only on one side of the prostate gland. And after 2 weeks, the MRI shows the only half of the prostate is ablated, the urethra is intact, and the gland is intact here. Having said that, the benefit of this is patient goes home immediately after this focal treatment, and he does not have to have the urethral catheter or any other to carry with them. And I have seen so many patients absolutely walk out of the surgery room and they're having a wine and dine in the afternoon while the doctor is still working, by the way, on other patients. So the statistics are the same in this one as well as 5 years. That metastasis-free survival means the cancer has not grown out of the capsule and inside the body somewhere else, 97% of the patients. Cancer-specific survival is 100% again. And that gives them the peace in terms of saying, my cancer is gone, rather than living with the cancer. So how do we compare this now? So when we do the radical prostatectomy, what you see is the yellow border, whole prostate is removed. When the radical radiotherapy is done, not only the prostate, but the whole pelvic region is being treated. When you do the focal, as I re-emphasize, you only treat the targeted area and nothing else. So how does that compare in terms of the overall outcome? So the major issues related with any of the procedures with the prostate are urinary incontinence and erectile dysfunctions and bowel motions, etc. With the focal therapy, almost all of that goes away. And this is the revolution what we are talking about in terms of prostate treatment with HIFU or any energy that can focus on the target. And I think, yes, reimbursement are very, very important, but when you talk to the people, those who are diagnosed with prostate cancer, they want to get treated. So we have huge number of centers now established in all over the world where the sonoblade and ablatherm devices are being used. Over 40,000 patients have been treated for prostate cancer now with focused ultrasound. And I think there are going to be more and more people going towards that in terms of once they find out how good this thing is going to work for them. Now, as my friends, I'll tell you, there is going to be a lot of competition because there are other energy modalities as well. I'm a great believer in therapeutic ultrasound, but there's, the good things are going to happen overall. And I like this chart. I think the Focus Ultrasound Foundation has done a great job of showing us how many things are happening in real world in terms of getting us into the clinic. It's going to take time, but most probably, I think we will be able to treat pancreatic cancer as well. And it might take a little longer to develop those things, but I don't think it's out of question. So having said that, as you can also see how many countries and how many companies are down there. And I think really our job is to getting things done in the hands of the clinicians as much as possible so we can get the feedback and learn from their problems, how can we solve these issues, what they face. So our society problem is really, how do we learn the disease, and this is of course, multidisciplinary society, and it will help us a lot if we start collaborating with them. And we have to get those instruments out from your lab into the clinics. And this is a challenge for us. You told me many years back that this was one of our tried problems, that we didn't let that go out. We have to get this out because there are so many patients who need help. And a targeted therapy is the key for them. And I tell you, I've gone my personal life as well as my friends, chemotherapy, etc., has a tremendous side effects. And ultrasound, very less side effects, or very minimal. If we perfect the instrumentation, I think we can reduce those side effects, not only side effects, but economic burden that our societies have in terms of taking care of patients. Well, I want to thank, of course, our company executives because they fund me and they pay me to do the work. But without them, I could be here today. Takai Hospital, our Japanese partner, played a major role, got me out of from the hospital into the real world, and our clinical collaborators. They have been excellent, and they've been very supportive. Like I gave you an example of Dr. Ahmed at Imperial College, at Oxford University, etc. They take risks when they see good things, and they help you understand the process, how the medical community works. Every country has their own rules, but at the end of the day, every human is the same. And we are treating the same cell, no matter where you go. And there are, of course, huge number of research, as well as university organizations that supported me. I have to go back. You know,